So again, we'll start exam reviews next week for exam 3, which will be in week 9. So we'll put you have your exam reviews. Just make sure if you can that you attend one of the live reviews if possible. Um, at least watch the live reviews or recordings of the live, oh my gosh, tongue twister, of the live reviews. And if you have any questions, need anything that, clarified, anything, please reach out to me. Don't go into an exam with, questions or, excuse me, unclarified information. I think as far as housekeeping, that is all exam or the homework grades will be turned off next week too, so then you'll just have access to your KGA scores. All right. See who is here. We got Asia, we got Brittany. We have Natalia, we have Gabriella, Kizzy. Let's see, who are we missing? Aliska is not here yet.
Nunca le busca el mensaje. Eh, dile que no. No,
All right. All right. So for today, for week 7, we are going to do chapters 15 and 16. So this is going to be all about the different healthcare settings, and then we'll discuss healthcare financing. Lots of terms, lots of different things. We're going to talk about, yeah, all right. So I don't know if anybody has had a chance to look at chapter 15 or 16 yet, but we will go ahead and get started. So I'm going to share my screen so you guys can see the PowerPoint. All right. So again, chapter 15 in your success in practical vocational nursing is all about healthcare settings. So this also too could be potential job sites for you as you are getting ready to finish your programs and start looking at potential employment opportunities. Oh, I don't know why this is not working for me. All right. So this is a table. This is a comparison of healthcare agencies, and we'll go in a little bit more depth with these. But this is just kind of like I said, it's just kind of like an overview of the different types of agencies that are out there. Um, so all healthcare entities offer a vast array of services. They're owned and operated either by public or government entities and private entity entities. They also include like for-profit and nonprofit. And so again, these are just the differences between the public and private healthcare services. So we'll go through, like I said, I'm going to go through the chart and then we'll go into a little bit more. So your public agencies, right? We have our public agencies and it is broken down into our official and our non-official agencies. So we think official, we think government, right? It is supported by tax money. The programs offered usually are disease prevention and wellness promotion. Sometimes they will direct services of healthcare, but their accountability, because they are, right, they're supported by tax money, that accountability is going to be the taxpayers as well as the government. They offer both mandated and non-mandated service programs. Your non-official or your voluntary public entities, they are supported by voluntary contributions and fees for service. Okay, so people donate money to these organizations. They offer services, mostly research and education, but they may offer some direct healthcare services as well. They are responsible to their supporters. So those people that are making those voluntary contributions, they may have a board of directors, and their programs are determined by their supporter interests. Okay, so their supporters that make those voluntary contributions may have some input into how what programs are offered. Private companies or private healthcare entities, they are supported by fees for service, meaning they bill for the services that they provide. So whether it's private pay, whether it's through an insurance company, whatever that is, that is how they receive their support. Their goal or their primary service is curing illness and disease. So, but they also may focus on disease prevention as well as wellness promotion. And they are going to be accountable to their owners. Okay. So, whoever owns that healthcare entity, that is who they are responsible to. And then the organization itself is going to define the goals. So, who are the owners, the board of directors may be the ones that determine what programs are going to be available. So, we'll break it down a little bit more. Again, here's your public healthcare agencies. Okay. Again, there's two different types. There's your official and your voluntary. Official government agencies are nonprofits. They are tax supported. Okay. So that makes them accountable to taxpayers as well as the government. They focus more on delivery of disease prevention and wellness promotion programs, and they also may provide some direct healthcare services. Your voluntary healthcare agencies are supported by voluntary contributions. They are also generally nonprofits. Okay, they also may charge a fee for services. And when we look at voluntary healthcare agencies, that fee for service is often based on that patient's financial ability to pay. A major emphasis is on education and research. They may also offer some direct healthcare services. And the activities are determined by the supporter interest, right? So they are supported through those voluntary contributions. So those supporters may have some input as to what activities are going to be offered. Some of our official as well as our voluntary, so either one of these, they operate at both at the local, the state, the federal, and sometimes even the international levels. So some examples of public healthcare agencies, big one at the local level is we have our city or county health departments. And so they are funded by local tax money. They also may get some subsidies from the state and federal levels of government. They carry out state laws, which are mandated programs concerning community health. And they also may carry out some non-mandated programs like health promotion programs. In collaboration with other governing agencies, they also may respond to community health issues. So if there's like an outbreak of a contagious disease. So when I was in my bachelor's program, feels like 150 years ago, um, I was already an RN and I then went back to get my bachelor's degree. And so didn't have a whole lot of clinicals to do because like I said, I already had my RN, but we did have to do community, um, clinicals. And so I spent, a week at the health department. And so I went through I guess various departments within the health department, but I did get to spend a few hours with the epidemiologist. And so epidemiologists, right, they look at the prevalence of disease and things in the area. They also respond to outbreaks. And so she told me that when she like early in her tenure at the health department, um, as she was telling me a little bit about what she did, she was telling me that, they do respond to community or to outbreaks. And so they had an outbreak of salmonella. Um, and there was like, I think across there was like about two or like maybe 200 people, all had salmonella. So, and they had to kind of, figure out where it came from, right? Because that can be a huge issue. And it turned out that I think she said it was a wedding. So there was some undercooked or improperly prepared chicken that was served at a wedding. And so anybody that was at the wedding that had that chicken ended up getting salmonella. So they will respond locally if it is, a larger outbreak of something. Then they can also have other government agencies come in and assist, and do like the investigation and things like that. There's also a state health department. And so each state has its state health department. And so it is funded by state tax money. And it also may receive some funding from the federal government as well. And then, of course, we do have the federal level. And so the official health agency at the federal level is the U.S. Department of Health and Human Services, or DHHS. It is funded by federal taxes. The head of the agency is appointed by the President of the United States, and this person who heads the Department of Health and Human Services will advise the president in any health matters. The Department of Health and Human Services has 11 operating divisions, including 8 agencies in the U.S. Public Health Services. So that is some of them are listed here. So the U.S. Food and Drug Administration, I'm sure everybody has heard of the FDA. It ensures that food, human and animal medications, biological products, and medical devices and electronic products that emit radiation are safe and, if applicable, effective. Okay, so anything we put in when we think of medical devices, so like your, oh my gosh, pacemakers, defibrillators, I don't know, I couldn't remember that, implantable ports, your artificial joints, all of those need to be FDA approved, right? To make sure that they are safe for human use. Okay, so they do go through an FDA approval process. We also have the Centers for Disease Control and Prevention, or the CDC. They provide leadership in health prevention, health promotion programs, and they also respond to public health emergencies, right? So if you remember during COVID, right, the CDC was the one that was really providing a lot of updates, right, regarding what was going on, what we should do, what we shouldn't do. And then we have the National Institute of Health. So the National Institute of Health, it funds biomedical research in its own labs, as well as in universities, hospitals, private research institutions, and the private industry. They also trains new researchers. It promotes collecting and sharing medical knowledge, and it consists of 27 institutes and centers, and it also includes the National Institute of Nursing Research. So yes, there is a National Institute of Nursing Research, which is actually pretty cool. And then we have some voluntary agencies. Okay, so voluntary agencies, these are non-official healthcare agencies. There's many more than just these ones that are listed on here, but like your American Cancer Society, the American Diabetes Association, American Lung, American Heart, we have Alcoholics Anonymous, La Leche League, we have, what else? We have Narcotics Anonymous, we have the Easter Seals. We have Alzheimer's Foundation. I think that's the name. I think it's Alzheimer's Foundation. The American Stroke Association. So there's a number of these volunteer healthcare agencies that are available. And these are really good to know that they're out there. They can provide support to patients. that may, be experiencing one of these issues. There's, other, educational opportunities. There's support groups. And so these are some really good agencies to be aware of, so that, we can help our clients or, get additional information and other services that they may need. And then we have private healthcare services. So most of us are probably more familiar with private healthcare services than we may be with the public. And so these two can be proprietary or for profit or nonprofit. Um, and so usually, again, private healthcare agencies, this is where most of the people get their healthcare. Um, so they do charge a fee for their services. And so there's a variety of ways, whether it's through co-payments, health insurance, or, even government-based programs like your Medicare and Medicaid. Um, we have had a huge shift with private healthcare agencies too, looking more so at disease prevention and wellness promotion. Um, let's see. So again, private healthcare. Family practice is a big one. They deliver primary care. They refer to specialists if additional evaluation is needed, right? And not everybody has primary care. A lot of us have primary care. And that's usually, the point at where we enter the healthcare system. So you go to the doctor for whatever reason, whatever is ailing you or bothering you. And they can, of course, provide care for you, or if needed, maybe you need to go to orthopedics, right? So they'll send you to an orthopedist, or maybe you need to go to, I don't know, an endocrinologist, a neurologist, right? Whatever it is you need. So, they can provide those referrals, and they also can kind of try to coordinate your care with you, right? So it doesn't become overwhelming. And we also have the private practice nurses. So, private practice nurses, these are advanced practice nurses or APRNs, that a lot of your APRNs practice in all aspects of healthcare. So, you'll find them in a variety of areas. But especially in our rural areas, they fill an acute need, where sometimes other healthcare provider services are difficult to obtain. Okay, so that is also something that came about with the Affordable Care Act. It has fueled the need for our advanced practice nurses in all settings. But again, especially in these rural settings where they may not have access to providers, these advanced practice nurse practitioners or advanced practice nurses fill a tremendous unmet need in those areas. Everybody still with me? Any questions? I know it's a lot. Then we have types of hospitals. Um, and so there's like, I don't remember what I think it's like, it's well over 6,000 hospitals in the United States. And sometimes it seems like a big number, and sometimes it seems like a really small number when you think about it. Um, but with our hospitals, the majority of hospitals are in three different groups. They're community hospitals, they're federal or state government hospitals, they are non-federal psychiatric hospitals, and then we also have our critical access, we have volunteer community. So there's a variety of different hospitals that are available. Um, Depending on where you live. So when we look at community hospitals, these are general, just a general community hospital, okay? They provide medical services. And so usually we consider this like an acute care setting, right? Some people get admitted directly from a doctor's office, other, may get admitted through the emergency room, whatever. But for most conditions, that general hospital can accommodate their client's needs. In some cases, in certain like serious or unusual medical conditions, they may not have the specialist there on site. And so then, their job then would be to stabilize them, and then transfer them. And so that leads us to our specialty hospitals. Our specialty hospitals offer services related to a particular disease or condition. So things like your trauma hospitals, your what's the other one? Like the heart hospitals. Some people, may know that some areas have like specific heart hospitals. They may have like an orthopedic hospital or an orthopedic unit that's separate. OBGYN, there's a variety of different types of specialty hospitals um, that offer these kind of cares. Usually it's highly skilled individuals with advanced knowledge, right, that are like particularly or that specialize in whatever that hospital is specializing in. Then we have our voluntary community hospitals. So oh my gosh, voluntary community hospitals. These are those that are associated with community associations or religious organizations. They are nonprofit. They usually provide short-term inpatient care for those that have an acute illness or an injury. These are also, though, very dependent on donations and gifts. So anybody know of any, like there's a few of them like that you probably see on TV quite often or hear them on the radio. Anybody have any ideas about which one of the like about give me an example of like a religious nonprofit organization? No. Um, let's
Is St.
see.
Mary's one?
Where's St. Mary's? A lot of people keep saying so that I've heard a couple people say St. Mary's today. Is that so that would be probably is it if it's like the Catholic organization?
Yes.
Yeah, so then definitely. We also have like anybody heard of St. Jude? St. Jude's Research Hospital.
Oh, with the cancer kids?
Yeah,
Okay, yes.
so that's a big one. We also have, I don't know if anybody has heard of the Shriners Hospital. Anybody heard of Shriners? Um, so it's interesting. Like I've heard about Shriners Hospital. I don't remember. I don't know. Like, sometimes you remember things, sometimes you don't. But I remember like all of a sudden they've got a lot more commercials now too, looking for donations. I don't remember them as being as um I don't know what the word is, exposed. I don't know the word. I don't think that's the right word, but usually you hear St. Jude, I remember as a kid, doing, I think it was like some kind of jump rope thing to raise money for St. Jude. Like how many times can you jump rope? Like, and you asked your family for donations and you donated it to St. Jude. So a variety of things out there. Um, I worked for a nonprofit children's hospital, and we were always doing, different types of fundraisers, right, in order to raise money for the hospital. But they're heavily dependent on gifts and donations. They usually will have a board of trustees to oversight of the hospital, but there is usually a paid administrator that is going to manage the hospital itself. And then we have um, federal or state public government hospitals. And so these are like your Veterans Administration, your state, or what is it? The state, county, municipally owned, operated nonprofit hospitals. These are also hospitals for people with serious mental illness. Again, they're funded by federal, state, or county funds. So this could be like your state psychiatric facilities. Obviously, the Veterans Health Administration is going to be separate from, other things. Those are usually funded federally, more the less so by the state. And we have teaching and research hospitals. So, teaching and research hospitals, they treat clients, especially those with serious or unusual conditions. They're often training sites for healthcare professionals, and it's nurses, doctors, other people as well. They also conduct research and development. They do clinical trials. These are mostly affiliated with your medical schools. So, like if I think of like some of these, think of the big ones, I think of Boston University, I think of like Vanderbilt, Johns Hopkins, which is a big one as well. When I lived in Virginia, we had Eastern Virginia Medical School. That was local for me. And so you would hear the advertisements, they would do research, clinical trials. So they were always trying to recruit people to come and do those clinical trials. But again, with, access to teaching and research hospitals, they have highly skilled practitioners. And again, they're mostly affiliated with medical schools, but like ours, we had Eastern Virginia Medical School, our Children's Hospital, and our Heart Hospital. They were all on the same campus. And so, yes, there were a lot of med students and even nursing students. And so, but again, some of these doctors have been in practice for many years. They have very, lots of skills, lots of experience. And so, lots going on in those areas. Then we have critical access hospitals. And so critical access hospitals, these are small. There's no more than 25 inpatient beds. They average length of stay is no more than 96 hours for acute inpatient care. It is 24/7 emergency care as well. These are located more in your rural areas. So at least a 35-mile drive away from any other hospital or even another critical access hospital. So if, something, extreme, illness, injury, that kind of thing, then their goal would be to stabilize and then transfer them to a larger health system, right? But goal is, we'll stabilize them and then we'll get them somewhere that they need, a little bit more higher level of care. And then outside of the hospital, okay, so we look outside of the hospital, we have our ambulatory services. And ambulatory services are offered in a variety of settings as well. So they can be in an outpatient hospital, they can be a nursing care center, they can be a health maintenance organization, they can be healthcare provider's office. We have freestanding, we have some that are attached to hospitals, but generally speaking, with ambulatory services, the cost is a little bit less expensive than going to the hospital, right? So like it's the same thing, knowing when to go to emergency room, when to go to an urgent care, right? The urgent care can provide emergency services at a little bit, at a lower level than the emergency room can. It also is going to be a little bit less expensive. And it's also for people who live independently or are cared for at home. And it does do assessment treatment as well as care coordination. So that's a big part of it. So your outpatient clinics. Outpatient clinics provide follow-up care to clients after hospitalizations. They can also manage disease on an ambulatory basis, meaning they don't need to be in a hospital. They can be part of a healthcare facility or they can be freestanding, which means that they're not attached to the hospital. Like I said, you may have a hospital and on one side of the hospital, you have all your inpatient thing, all inpatient floors and all of that. And then on the other side of the hospital, you may have outpatient clinics, right? So it could be, the different, your ENT, your nephrology, your GYN. It could be, I'm trying to think, GI, what else? Endocrine, right? Variety of different services that are offered. Generally, you will need an appointment as well. Usually not, oh, and outpatient clinics are generally not in walk-ins. Your urgent care centers, on the other hand, are walk-ins, right? So you wake up and you don't feel so well, feel like you need to go to the doctor, right? Versus going to the emergency room and your doctor's office is closed, then you can go to an urgent care center. So urgent care centers make primary health care available as an alternative to a family health care provider. Okay, or obviously, to using the emergency room. It's also used by people who don't have a family healthcare provider, right? Not everybody has a primary care provider, and they may use urgent care centers as their primary healthcare providers. It is, also pretty much, also more convenient, right? So if you work 9 to 5 and that's the same time that your doctor's office is available, right? Then, you can, use this after hours, right? When you get off work. And a lot of the urgent cares are open, right? Till like 10, 11 o'clock at night. It just depends. And then, of course, the name is going to tell you what type of services they provide. So, convenience clinics, express cares, quick care, urgent care. I was telling the group earlier today. So, when I lived in Virginia, if I looked in just like a few mile radius, I had probably a hospital and maybe two or three urgent care centers. I moved down here and within a 2 mile radius, when I Googled it one time, because I needed to go to urgent care, um, there was 13 in a 2 mile radius, 13 urgent care centers. I was like, this is crazy. So they're like, how you have like those little strip malls, maybe have like two or three shops in them. There'd be like an urgent care in the corner. Like, and they're like all over. Like, it's so crazy. There was no wait. I mean, that is one thing I will say that was a benefit. I didn't have to wait. I got there and I was, taken right back and I was in and out, I think in under an hour and a half. So, it was actually pretty cool. But there, it depends on, I don't know what it depends on. I used to think it was population based, but um did a just a quick scan to see like what the population difference is between here and there is. And there's actually per, when we look at like how many people, there's actually more people where I was living in Virginia than there is here. And I just thought that was interesting, but no shortage of urgent care centers down here. All right. Um, let's see. And then we have 1 day surgical centers. So, 1 day surgical centers, or what we call ambulatory surgery centers, they, let's say you need to go in and have your tonsils taken out, right? So you get a scheduled date and time. You go in the morning or whatever time, they tell you to be there. Get your tonsils taken out, and then once you recovered from anesthesia and you're considered stable, you go home, right? That would be an ambulatory surgery center. So these, again, eliminates the charge for being hospitalized overnight if you don't need to stay overnight in the hospital. Um, Now, with the 1 day surgical centers, I will tell you that some of these are freestanding and some of them you'll find in a hospital. So when you're working in the hospital or you go to the hospital, you will see outpatient surgery and you'll see inpatient surgery. All right. So outpatient surgery means that they're not spending the night. They didn't spend the night in the hospital. They're not going to spend the night in the hospital. They check in prior to their surgery. They have their surgery and they go home. And then there's also, I'm sorry. There's also, they could also be separate. Um, So you may see like an ambulatory surgery center that is not attached to a hospital or part of a hospital. It's a freestanding clinic. So there's that option, their option as well. And most types of surgeries can be performed in these settings. They will not do complex surgical procedures. Okay. So like you're not going to have, a valve repair or a CABG procedure. They're not complex surgeries. Okay. These are simple procedures that, they can go in, get what they need done, and, go home safely that same day. Free clinics. So free clinics are just another alternative way of providing primary care. It's either free or it's reduced fee. Okay. So it's for people who can't afford traditional health services, or maybe they're even reluctant to use those traditional health services. And a lot of times um, the fee is based off of what your income is. Okay. So they'll look at your income level and that's how they will determine what your cost for care is. A lot of them will have either an income limit or some have an age limit as well. They are usually staffed by volunteer healthcare providers as well as nurses, but there's usually like one person, like a salaried person who will run the clinic, and then they'll have a volunteer board to make decisions, on policy decisions and things for the clinic. Now the free clinics, of course, is going to vary by where you are, um, and the availability of healthcare services. So, like I know where I was at, we had one free clinic that was pretty popular, but it wasn't centrally located, so a lot of times it was hard for some people to get to that clinic. I haven't looked down here to see how many free clinics are down here in this area, but those are an option for people that may not have health insurance or even healthcare providers. So if the availability is there within their area. So when we look at other types of facilities too, these are also more community based as well. When we look at skilled nursing care, so long-term care facilities are designed to help people with disabilities or chronic medical needs. Skilled care is considered care that is medically necessary to improve the quality of the client's health or to maintain or slow decompensation of a client's condition, right? So we're going to get into more about skilled nursing care when we start talking about some of this. So not everybody's goal when they get older is to go live in a long-term care facility, right? I know it's not my goal as I get older. Definitely not my goal to go live in a long-term care facility. So there are alternatives. And home health services is going to be one of those alternatives. Now, I will tell you, I don't know. It really depends on the person. Is anybody interested in doing home health? Has anybody thought about doing home health? Because you said yes. No. Katrina said no. Um, I'm not, I don't want to do health. I thought about it at one point. I was like, oh, home health sounds like a good idea. And then I said no, because I don't want to go into other people's homes. There's a variety of reasons. One, I feel like it's invasive, but that's beside the point. But I will say that home health is probably going to have a huge explosion, just because, when we look at this baby boomer generation, so the baby boomer generation, right, largest generation, we're going to lose a whole large bunch of people. But as they age, so the youngest of the baby boomers are in their early 60s. So there's still some time. But again, they were the largest generation. So right now, as it stands, there are not enough long-term care facilities. There are not enough geriatric providers. There is not enough geriatric nurses. So home health, I have a feeling home health is going to have a big explosion too, because right, we're going to have to take care of this population as they age. But it is an option. Home health agencies, they can be public or they can be private. And again, they provide home health services. And so they, can do pretty much anything in home health anymore. Um, so, we're focused, it's more relationship centered care, right? So you're not just focused on the client themselves, but you're also focused on the families and helping the families and, what their needs are. The purpose is to promote, maintain, or restore health or minimize the effects of illness or disability. And a lot of it is going to be education, right? So home health is not forever. It isn't a forever thing. And so a lot of what the home health nurses do is go in and provide education so that, we can teach them, how to do the wound care. We can teach them, how to do the tube feedings or whatever the specific need for that client is. And RN is usually the case manager, but LPNs, CNAs, sometimes even volunteers are all part of that patient's care. But some of the services would be that skilled nursing care, PT, OT, speech. They may need social services. They also may need respiratory or podiatry or nutritional services. Um, what is the difference between a home health aide and a CNA? Has anybody heard of a home health aide before? So what's the difference between a home health aide and a CNA?
It's not the same. Like they help the patient with the daily activities, or no?
You're on the right track. Yeah, no,
CNA has to
absolutely.
sit for their license.
Yeah, CNA does have to sit for their license. So when I first started, I actually was a home health aide in Florida before I joined the Navy, but so and I don't know if that, obviously that was a really long time ago, so I'm not gonna say anything, but um we were trained to do vital signs. Okay. I don't know if they are still trained to do vital signs now or that, but like basic things like transfers, like, some cooking, some light cleaning. I could escort them to doctor's offices. I could take them grocery shopping, right? So it's more home, like, you know, it's not medical technically is what it would be. Okay. So like my one client that I had, um, it was an older couple. They had a disabled daughter and had gotten to the point where they were still, alert and, mentally and physically fit. They just couldn't transfer her anymore. So I would go over in the mornings, I would get her out of bed into her wheelchair, and then in the evenings I would go back and put her from her wheelchair back into her bed. Like that was the extent of what they needed from me. Other clients, I did a little bit more, but it just really kind of depended. So yeah, they're not necessarily medically trained. Like I said, we were trained to do vital signs. So in the event something were to happen, I could do vital signs and report those off to the nurse. But those are nice, some services. Like I said, also did some cleaning, some grocery shopping. There was one that I would go to her doctor's appointments with her. So it really just depends. When we look at skilled nursing services are provided and directed by the registered nurse. And then, of course, the LPNs are going to do the basic nursing services. So it is still a combination of team nursing. So education, like I said, one of the main goals of home health nursing from nurses is to provide the education to the family so that the family or even the patient can take over care because it's not going to be a forever service. So teaching, supervising, giving meds, preparing medications for self-administration, giving injections, glucose testing, Actually too assisting in creating a safe environment is a real big key too, right? So, like I said, not I don't like going into other people's homes, but doing that home assessment is important, especially too, right? When we look at somebody who maybe is recovering from hip surgery, knee surgery, a stroke, right? And we're using walkers and wheelchairs or canes within the house, right? So what are some ways to help make them safe? Right? Removing those throw rugs, right? Moving the cords out of the way. Sometimes we may even have to, recommend they move some furniture around, installing grab bars, right? So helping that family create that safe environment. And then wound care and ostomy care and bowel and bladder retraining, oxygen and respiratory care. People go home with Foley catheters all the time, right? They also may need to even perform some self-catheterizations, right? So there's, lots of education, lots of opportunities for them to learn how to care for themselves. And then we have our other types of care. So community health nursing. So community health service, when you think about the history of LPNs, and I don't know if you guys remember all the way back, I think in week one, right? Then one of the primary functions of the LPNs was community health nursing, right? LPNs were out in the community offering a variety of services to clients in their homes. um, and so, that is a goal of nurses. We've always been part of the community. And so the main focus of your community health nursing is to improve the health status of communities or groups of people through public education, screening for the early detection of disease, and then services for people who need out care outside of that acute care setting. So, adult daycare centers. These are awesome. Like I can't say enough about adult daycare centers. Some of your adult daycare centers are hospital based, others are freestanding. And so in Virginia, we had both. We had some that were hospital based and we had some that were freestanding, but they provide services for those who need supervision, whether it's because of physical needs or safety needs, but they're not candidates for living in a nursing home. Usually these are people who live at home. Maybe they have, maybe they live with family, and they have caregivers in the evenings and on weekends. Um, but maybe they're just not safe to stay at home during the day for whatever reason. Maybe it's ambulation, like they wouldn't be able to get up and, I don't know, get themselves food and fluids during the day. It could be because they have, dementia or other issues going on, whatever the reasons, but they're just not a candidate for a nursing home. So, and if, you're at home and you're taking care of grandma, you're taking care of mom, and, you don't want to leave her at home. So we have these adult daycare centers. And so they're great. They provide socialization, mental stimulation, and some, depending on where it is, they may even offer assistance with ADLs, but they're in a nice, safe environment. Other things too, some of them even offer transportation. So they may even pick up and drop off grandma. Most they will have meals available as well. And usually they're run by a social worker. It could be a nurse that runs these as well. They also may have CNAs or like personal care assistants that are on staff or volunteers to help with some of these people during the day. But these are really good services. I don't know if has anybody heard of PACE before? It's PACE. It's Program for the All-Inclusive Care of the Elderly. Those are really formal programs. They're offered through a lot of your hospitals. They do like they'll pick them up in the morning, they'll bring them to their center. Some of these programs have like healthcare providers on site too. So like if there's an issue, They can be seen or they need, have an appointment. They can be seen by their healthcare provider. So some of them are really cool. Again, like prices, all inclusive. So they pick them up, they drop them off, they do a whole bunch of different things with them. We have residential care homes. So these are a little bit different. Residential or board and care homes, whatever you want to call them. These are usually they can offer temporary or long-term, okay, but they're usually for like those that have occasional mild cognitive or mobility issues. Um, they, they're like use a lot of the ones that I've seen are just like regular homes that somebody has bought and transitioned into a care home, but they will get assistance with their ADLs, um, usually a self-administration of medication, meal preps, transportation. Those are usually provided by the owner or the manager. And so, it just really depends. These are overseen by the Department of Social Services. And so I was telling the group earlier today, my neighbor when I lived in Virginia, the one that lived, she lived across the street from me. When I first moved in 30 something years ago, she actually owned a medical transportation business. So she had a bunch of vans. Um, so she did mostly, I don't think she did stretcher. I think she just did ambulatory and wheelchair. And then as, she started, as we all started getting older, she decided to open a care home. And so she bought another house in the neighborhood actually, and she was it transitioned it and make sure that I was up to code and all that stuff into a residential care home. And it was very well regulated up there. So I was telling the group when I came down here, I realized, or I learned, not realized, I learned that the residential care homes down here, even though they fall under the Department of Social Services, they aren't as monitored. So we had a client. This was over the summer, last summer. So we had a client or a patient actually. So I forget what happened. I think he had fallen and he fell and he did something. He didn't break anything, I don't think. Maybe he has had, I don't remember why he was there, honest to God. I just know he was getting service. He was getting PT and OT. He was nonverbal, and he was in his early 40s. And I don't know at what point he became nonverbal. Only reason why I say that is because they said that he used to talk and then all of a sudden he just stopped talking. He made noises, but he wouldn't speak. And he was diagnosed with schizophrenia, which I thought was odd since he was nonverbal, how they could diagnose him with schizophrenia. But long story short, so when it came time for him to be discharged, now he had been in this residential care home since he was 18 and he was in his 40s. So he had been there for a really, really long time, like what, 30 years? They refused to take him back when he was being discharged. And he had some behaviors, I'm not gonna lie. That was the first resident that I had ever gotten punched in the face by. Like I'd never been attacked by a resident until he came around. Because I told him no. Because he was trying to pull stuff off of the med cart and I just very firmly said no and wasn't expecting it. Um, but anyway, um, they refused to take him back. Well, the social worker at the facility had tried to reach out to the care home. This poor man had lived there, like I said, since he was 18 and he was in his 40s. They refused to bring him any clothes, no shoes, no socks, no underwear, nothing, none of his personal cares items. So we had made like numerous requests to the care home for him to like get his clothes. And if you've ever been in a long-term care facility, when we have residents that don't have clothes, we go to the laundry and we find clothes that either have been donated or for residents that are not there anymore or, that have passed away and the family has donated their clothes. But this man was tall and he was thin. We had like no clothes that fit him. So the staff we ended up buying him like sweatpants and socks and shoes and stuff. But these care home has been collecting his money for this 30 years that he was there. And I honestly can't even tell you if he had any clothes because they absolutely refused to bring anything. And like I said, they refused to even take him back. Our social workers ended up having to find him another because he didn't qualify for long-term care. But it was really sad. So that is when I learned that depending on where you live, is going to be how well supervised some of these places are. But I thought it was really sad. Like, I really thought it was really sad. And then we have continuing care retirement centers or yeah, continuing care retirement community. These are also pretty cool. And there's different ways that these are set up, but it is a continuity, it's a continuum of living options. So from independent living, assisted living, and skilled nursing all on the same campus. So you literally maybe in different buildings, right? So maybe they're living in the independent living, and let's say something happens. Maybe they fall and they break a hip. They go out, they have surgery, they go out and have surgery, and now they need some skilled care for PT and OT. So they can go to a different part of the campus, get their skilled care. And then when they're done, if they're safe to go back to their independent living, they can, or maybe they need to go to assisted living instead, but it is all one campus. And so they literally can go from one part of the, campus to the next. It also, they get familiar with the area, they meet friends, it's socialization. And so they stay within that one area, right? So instead of having to go to a completely new facility and, lose all their friends and things that they used to do. And some of these are really cool. I was watching, I looked up at one. They had swimming pools. They had one had like a go-kart track. I figured like I don't understand. That to me looked a little bit dangerous, but okay. But they have like a lot. So depending on where the area is, of course, is going to determine what 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 do you call it? What services they provide. But so there's a lot of different ones out there. I will tell you some of these are really expensive. Before we put my mom into hospice care, she had thought about going into, at first she thought assisted or an independent living, and then she was like, maybe assisted living would be better. Um, and the assisted living, and this was like 10 years ago, was like $4,000 a month. And that only included 2 meals a day. So, and not so the third meal of the day would have to be an additional out-of-pocket cost. And I was like, so she decided just to stay with me, rather than going into the assisted living because it was like super crazy expensive. All right, well, I'm gonna hold off there, so we can go and we can take a break. So be back at 6:40. Mm. All right. So we talked about hospitals and we've talked about some community settings. Now we'll talk about some more institutional settings. So we have rehab services. I guess these would still be community, but the purpose of rehab settings or rehab services is to return, its focus is to on a return of function and prevention of further disability. So depending, of course, what they're having rehab services for, we want to get them either back to their previous level of functioning or as close to their previous level of functioning as possible. So there's a variety of settings that offer rehab services as well. And so we can do it in a rehab center. So there are some areas that have, just rehab centers or rehab hospitals. We have the long-term care facilities. They can be done in outpatient facilities, in residential homes, or in the client's home as well. And so the focus again regarding where it's set is return of function and preventing further disability. And so it also, depends on their illness, or their injury, how long those rehab services are going to be needed. Another type of center is a wellness center. And so per wellness centers, again, it is to promote wellness, detect diseases in early stages. So they can do nutritional counseling, exercise programs, stress reduction, weight control. The private sector is more, active in wellness area. So this is like your exercise and fitness clubs, um, things like Weight Watchers, what else? Smoking cessation classes, stress control parenting classes. Um, they also, can exist within, a clinic or somewhere, or they can be freestanding. And a lot of times your LPNs will work in conjunction with either um, an RN or an advanced practice nurse in these centers to provide, guidance along the way. And then we have hospice services. So hospice is offered in many areas as well. Um, to those that have been certified as terminally ill. So generally, when we think of hospice, we think of end of life care. And it's to maintain comfort as death approaches. A lot of, another philosophy is death with dignity. Again, they usually will have a diagnosis of that is terminal, and they have 6 months or less to live if the disease runs its normal course. Now, that doesn't necessarily mean they have to die within that 6 months because I actually have patients and have had clients that have been in hospice for a couple of years. um, so it's, they generally just have that terminal diagnosis. And so hospice can also be offered anywhere. It can be in the hospital, it can be in a long-term care setting or a hospice home. So there are places that have hospice homes. Thought another really interesting thing that I learned down here. Um, you get pharmacy, the when they deliver the meds from pharmacy. I was talking to him one time and they have, I don't know what company it is. I don't know all the hospice companies around here, but one of the hospice companies, they actually rent out a floor of hotel rooms and they provide hospice services in their hotel, in the hotel room. So I thought that was another interesting, I never had heard of that before. Um, but, when we think about it, hospice, many people will, they want to die in their home, and that's perfectly fine. We can provide hospice services in their home. Other people may not want to die in their home, right? So that is why this is offered in a variety of settings. And I don't know if anybody has ever thought about working with hospice or have worked with, any hospice nurses previously. But it is something. Hospice nurses, the ones that I have met, are absolutely wonderful. And to be surrounded by death a lot, it probably does take a toll on them. But they, generally, are some really great nurses. One thing that I also found different down here is, we think of hospice, right? Death with dignity or maintaining comfort as death approaches. We actually have had a handful of hospice patients that are still full codes. So we will, still need to provide CPR in the event that something happens. My previous experience with hospice is that they were, once they admit into hospice care, they, go ahead and do the DNR. So it's just different. And so, like, we talk about Nurse Practice Act and, what the difference is between some of the states. That was something that was also really new for me, moving to Texas. And we had palliative care. So, palliative care does provide comfort care. It is similar to hospice care. The difference is with palliative care, though, um, care is often it can be initiated at the beginning of an illness, and it can be accessed at any time of that illness. And so while they are receiving palliative care, they still may choose to receive life-saving implementation. So this could be, we can provide palliative care to that patient that is receiving treatment for their cancer, right? And maybe they're experiencing some of the negative side effects from chemotherapy. So this could be something like even giving IV fluids to someone who's dehydrated. Um, so it's just palliative services. Not all palliative care is hospice, but hospice clients will receive palliative care as well, right? Because the goal is to make the patient comfortable. Um, and then it
Can
does,
I ask a quick question? I'm sorry.
sure,
For
absolutely.
palliative care, do you have to have a terminal illness to be on it or you don't?
Nope,
Okay.
nope. So this like something like when we think palliative care, I know a lot of we associate this with like death and dying and stuff, but palliative care is just promoting comfort. So this could be you have a patient who is like I said, maybe they've had some, extensive, they had a GI bug and they've got, vomiting and diarrhea and they're getting dehydrated, starting an IV and giving them IV fluids, that could be palliative care. So it's just making them comfortable. It's, your patient with I don't know, COPD, right, becomes short of breath, and we put oxygen. That could be a palliative treatment, right? It's just providing comfort. So no, they don't have to be terminal in order to receive palliative care. Again, it's just relieving symptoms, right? So, for example, I'll give you one. We had a patient who I forget what kind of cancer she had. She was undergoing chemotherapy and radiation for her cancer and was having a really hard time eating. And so just because of the effects of the chemotherapy, so we put a G tube in. Okay, so she's still receiving her treatment for her cancer. Now she has a G tube and we're providing for her nutrition. It could be relieving pain. It could be relieving, helping them sleep, supporting family members. So palliative care is a wide variety of options that we have, between medicine and nursing that we just help to make them feel better. All right, so lots of them, there's a ton of information in that chapter. Okay, so we talked about the different types of hospitals, right? We talked about government hospitals and voluntary hospitals. So we talked about public versus private hospitals. Um, so, again, the government hospitals or the official, they are nonprofit, they are supported by taxpayer money, they focus on disease prevention and wellness. Your voluntary, um, rely on voluntary contributions. They also may charge a fee for service. They do a lot of research and education. And we talked about, well, so we talked about the health department. So we have the local health department, right, in your city or county that is funded by your local tax money. They also get subsidies maybe from the state and federal levels. They carry out mandated programs, which are state laws. They also may do some non-mandated programs like your health promotion, respond to outbreaks. The state health department is also funded by state tax money. It also may receive some subsidies from the federal government. And then, of course, the U.S. Department of Health and Human Services. That is the federal government agents or the federal, what do you call it? The Federal Health Agency. Geez. It is funded by federal taxes. It has the head of the U.S. Department of Health and Human Services is appointed by the President of the United States, and it has 11 operating divisions. And so some of those federal agencies was your U.S. Department or U.S. Food and Drug Administration, sorry. So they make sure that our food, our human and animal medications, our biologic products, our medical devices and electronic devices that produce oh my gosh, radiation are safe. Um, we have the CDC, which is the Centers for Disease Control and Prevention. They provide leadership in health prevention and promotion programs. They also respond to public health emergencies, talked about COVID. We have the NIH, which is the National Institute of Health. They do lots of biomedical research within their own research labs, universities, hospitals, as well as in the private industry. They also have what is it? The National Institute of Nursing Research falls under that, National Institute of Health. Then we have the voluntary nonprofit, which are like your American Cancer Society, American Diabetes Society or Association, American Lung, American Heart, those types of programs. What else did we talk about? Then we talked about the types of hospitals, right? The community hospitals, the specialty hospitals. We also talked about public hospitals, which are like your Veterans Administration. Could also be your like state psychiatric facilities. Um, and then we have teaching and research hospitals. Those, like I said, they are usually affiliated with medical schools. So lots of education, research, and training that goes on in your teaching or research hospitals. What else? And we talked about ambulatory services, outpatient clinics, urgent care centers, your ambulatory surgery centers, talked about some free clinics, um, talked about skilled care, talked about home health, and then we talked about hospice. So, any questions on chapter 15? Because I know that is a ton of information. No? Are you sure? All right. So that will bring us to chapter 16. So chapter 16 is basically healthcare systems funding. Like how is healthcare paid for? Oops. All right. So historically, okay, um, the U.S. healthcare system has been described as a poorly organized and complicated maze of services that lacks preventive care, waste resources, and is very expensive. And anybody that's had any exposure to the healthcare services in the United States would probably agree with that. Um, and so it is, we can go back historically and look at this. So in the early 60s, the 1960s, um, so the healthcare provider's key role in healthcare decision making combined with a fee for service model is what led to those healthcare costs going out or going up through the roof. There wasn't a whole lot of attention paid to cost containment. So what does that mean? So we look at fee for service when it, just primarily fee for service. It's just like going to a restaurant, right? You go to a restaurant, maybe you order appetizer, you order your dinner, you order your dessert, you order whatever drink that it is that you want to drink, right? And then at the end of the meal, right, you get a bill and it shows you got your appetizer, it shows your meal, it shows your dessert, and it shows you what you ordered to drink, right? So a nice little itemized bill and you pay that bill, right? So, and then you go on your way. So it was the same thing with how healthcare used to be. Um, you go to the doctor's office, and let's say you had strep throat. Okay. So you go to the doctor's office, you're going to be charged the exam fee, right? That's just the doctor coming in and doing his examination. And then you're going to be charged for the test for the strep throat, um, the diagnostic fee or whatever that is, right? There may be some other small fees that are and added on there, and you get an itemized bill and you paid it. Um, so that's one reason, right? They didn't bother them, if the the tech was doing the strep test, dropped it on the floor accidentally and had to do another one, and they were going to charge you for like two strep tests, right? There wasn't a lot of attention that we paid to cost containment. Um, Procedures were offered if they might help. Okay. So it wasn't like, you have to have this procedure. It's definitely going to help you. It's like, oh, we'll see. But that also increases cost. So as a result of this, back in the 1980s, the Medicare changed from fee for service to a prospective payment based on what we call diagnostic related groups. And then eventually other insurances followed. And so basically, the hospital was paid for the client based on what their DRG was. And so a DRG means, let's say we have a client that's coming into the emergency room and they're having a heart attack. Okay. A DRG, this is an agreement. They've already let the hospital know at a prior time that if they have a client that comes in with a heart attack, they're going to get this set amount of money. Okay. No matter how much care you provide, this is the amount of money that you're going to get to care for this patient that's having a heart attack. That's what a DRG is. And so during that time, the more the healthcare was focused more on minimizing clients' length of stay, which we all know where that can go. And that became what we call utilization management. In most cases, the shorter the stay, the more at the hospital would make money, right? So let's say, you're getting $10,000 to care for this client with the heart attack. Okay. And let's say that just covers, I don't know, because I haven't worked for insurance for a long time, but so here's your $10,000. This is going to cover, let's say, a 5-day hospital stay and all inclusive, whatever care you provide. Well, if they're stable and we discharge them at 3 days, right, then that's 2 days basically that, their hospital is making money because that patient is not there anymore. And so as time went on, that payment system extended to healthcare provider payments, which led to managed care organizations becoming, or be the birth of healthcare or managed care organizations or MCOs. And so your MCOs are like your health maintenance organizations, preferred provider, point of service, and open access plans. So if you look at your insurance, and I don't know if anybody has private insurance, but if you look at your insurance card, it'll tell you if you have an HMO, if you have a PPO, if you have a POS plan, it will tell you on there. So there's a variety of different plans that are out there. I just said that. So, and then despite all those wonderful changes, okay, there was only a small improvement in healthcare costs. Okay, so we still had continuing increased costs. We also had inequalities in healthcare access. And so again, not all Americans had access to healthcare, particularly the underemployed. The poor also struggled with accessing healthcare, even if they had healthcare coverage. So we were still in this rut. So then comes the Affordable Care Act. Okay. So the Affordable Care Act was put in place, and I think it was 2010 during President Obama's term as president. So it was originally, we called this Obamacare. It was the first sweeping piece of legislation to address healthcare reform in the US since 1965, when Medicare was added to the Social Security Act. So between 1965 and 2010, we didn't have any other major healthcare reform. So the goal of the Affordable Care Act was to enhance the access and affordability of healthcare, particularly to all citizens in financial need in the US. And so obviously it has decreased the number of uninsured in the United States. Do we still have uninsured in the United States? Absolutely. Is it a far less number? Absolutely. Um, and so there were some really great things that came out from it. And so it established that health insurance marketplace. So that's a resource where, individual, a family, even employers like small businesses can go and look at their healthcare options, all right, or their health and coverage options, I should say. And so they can choose the plan, they can also enroll in coverage. And so it also, if people, those that are like low to moderate income, it also will help them with resources that will help to pay for coverage. Um, what else? It reduced prescription costs for Medicare beneficiaries. It also eliminated lifetime coverage limits. Has anybody heard of a lifetime coverage limit? You guys are younger, so you might not know about lifetime coverage limits. Has anybody heard that before? No. So lifetime coverage limits. So again, the Affordable Care Act got rid of this, but this was your maximum benefit. Okay. So let's say, and I don't, I've had insurance in the past that have had lifetime coverage limits, but let's say you have a chronic illness. I'm gonna say, let me think of a good one. Let's say you have let's say MS or diabetes. I'll just use diabetes. So you have diabetes, okay? And back in the day, a lot of people stayed in one job for 20, 30 years, right? And retired. So they had the same insurance for years and years and years. But um, once you hit that lifetime coverage limit, so let's say I'm just going to use a small number because it's easier. So like $20,000, okay? Which we know that's well below probably, hopefully. Once you hit 20,000, once your insurance has paid $20,000, that's it, they're done paying. That means that all the rest of your diabetic care for the rest of your life is going to have to be paid out of pocket. That was what a lifetime coverage limit is. So a little bit crazy, right? Could you imagine if, some of these people that have these chronic diseases, right, and they had those lifetime coverage limits, they're literally just Why have insurance, right? Because they're paying out of pocket for their health cover, or their health needs anyway. It also covers pre-existing conditions. So pre-existing conditions used to be a hassle. So again, that same person that had diabetes, let's say they, had to leave one job and go to their next job. There used to be a lockout on their insurance because of a pre-existing condition. So they wouldn't even be able to get care for that condition. And I forget how long it was. I think some of them were like as long as 6 months. So that's 6 months that a diabetic wouldn't have access to their insulin, their medications without having to pay completely out of pocket for those. So it got rid of those. Um, and then it also allowed the states to determine Medicaid eligibility requirements. Okay, so the Affordable Care Act has done a lot to help people get insurance and to get access to healthcare. When we also, another way we look at financing healthcare, the most two common ways are either fee for service or capitation. So when we look at fee for service, this was the traditional method of paying healthcare bills. Okay, was a fee for service. So like I said, you go to the restaurant, you get an itemized bill of what you ordered, you pay. That's the fee for service. Okay, so the physicians were paid a fee for service that they provide. And they were directly reimbursed for most tests, most treatments. However, some insurance companies do not reimburse for preventative or diagnostic tests in early stage diseases. Capitation is another interesting reimbursement. So, healthcare providers receive a fee per member over a designated time frame, meaning, let's say you have health insurance A. All right. And this healthcare provider has 100 patients that have health insurance A. Okay. So there's a set monthly fee that's charged for the provider for each member of the insurance group for a specific set of services, whatever that set of services is. Okay. If the healthcare services go above that monthly fee, then the provider has to eat that cost. But if the services provided were below that monthly fee, then that's their profit. So the goal is to keep the members healthy in order to make the profit. Because if I don't have to see the client as much and I don't have to extend those services, that's more money in my pocket as a provider. Personal payment or private pay, that was primarily the method before 1940s. You go to the doctor, you got a bill, you paid the bill, and you went home. And now we have health insurance. So we have private group health insurance and we have private individual health insurance. So group health insurance, this is usually what's offered through your job. Okay. So whatever hospital, whatever organization that you decide to go work for, they generally will offer some sort of health insurance for you. Okay. So the Blue Cross Blue Shield, Aetna, Cigna, United Healthcare. Okay. I'm trying to think of what else. Those are some examples of group health insurance. And so the Affordable Care Act does not require all employers to provide health benefits. So your employer is not required to offer health benefits. However, for large companies or large employers that employ more than 50 people, it will impose a penalty if they do not provide insurance to their workers or if they provide insurance that is not affordable. So, for example, again, going to use a really low number so I can do the math really quickly. Let's say you're making $10 an hour. All right. And you work a 40-hour week. So that's $400 a week, right? So 800 every 2 weeks, so 1600 a month. Okay, so you're bringing home 1600 a month. and you work for a big company, let's say you work for McDonald's, because we know McDonald's is a multi-million dollar company and it's a large company. It has more than 50 employees. All right. So you are a full-time employee, so you're available, you're what do you call it? You can get benefits. And so let's say they look at your benefits that they're offering, and your health insurance for you and your family is going to cost you $800 a month. You're only making $1,600 a month. That's before taxes, right? I didn't say anything about taxes yet. I'm just saying flat fee. This is what your base pay is. Is that affordable? Can you pay $800 in healthcare if you're only making 1,600 a month? No, right? That's just unrealistic. And so that's why the Affordable Care Act will promote, it will, impose a penalty if they're not providing affordable healthcare. Small businesses, like those that are less than 50 employees, they actually will give them a tax credit if they offer health insurance to those employees. So there's that. Then we have the private individual health insurance. And so again, not everybody has access to health insurance, but your individual health insurance. So some of your major insurance companies, so you can look Blue Cross Blue Shield, Cigna, Aetna, United Healthcare. Some of them do offer health insurance to individuals who are not part of a group. And premiums are usually based on their age and person's age and their tobacco usage. Um, you can also, like I said, you can go to the marketplace and you can look to see what programs are offered there. The marketplace may offer some plans that are a little bit less expensive than going directly to the company, but that's an option as well. So, health insurance terms. So, like I said, I don't know who has private health insurance. Oops, sorry. I don't know who has health insurance and who doesn't. Or maybe some of you have never had to pick your own health insurance. These are some terms that you really need to understand. These are super important. So, the first one is premium. So the premium is the monthly fee that a person must pay for the health insurance coverage. So like I used my little, fake McDonald's example. The premium was $800 a month. Okay. Hopefully that was a little exaggerative. I don't know anything about McDonald's. I did work for McDonald's as a teenager though, but I don't know anything about their health insurance. So I don't know how much it costs. I was just throwing numbers out there. Okay. So when you go get a job, some places offer you different options. Some places have one option. All right. It just really depends. But the premium, that's how much they're going to take out of your paycheck every month, okay, to pay for your health insurance. Premium is going to be different based on whether it is just you by yourself or is it you and your family, okay? The deductible is the amount that you must spend out of pocket for healthcare before your insurance policy will begin to pay. Okay. Trying to think. This can be anywhere from $1,000 to $5,000. Like it just depends. Um, and that's basically, like I said, that's what you have to pay before your insurance is going to kick in. All right. So, if a person that you never get sick and you only go to the doctor, once a year because you have to have your physical, okay, then you're basically paying, for you're paying to have insurance just in case at that point. But yes, so that's what that is. Um, your copay is what you pay when you go to the doctor. So like different copays for different levels of care. So for example, mine are like $25 for a primary care, it's $35 for a specialist, and then it's 50 and up for urgent care or emergency care, depending on what services are needed. So you have your premium that you pay every month. You have to meet your deductible before your insurance is going to kick in. You have to make your co-payments. Oh, this is also when you're picking up your prescriptions too. Okay. And prescriptions are different. They're based off of tiers, and that's what determines your copay for your prescription medications. Then we have co-insurance. So co-insurance is once you've met your deductible. So let's say you paid your $1,000 already and you're good to go. You met your deductible, so now your insurance has kicked in. This is the percentage that you must pay after your insurance. So it could be like 80/20, whereas your insurance is going to pay 80% of the bill and you have to pay 20%. So when you're picking your insurance company or your insurance when you start your job, these are the things that you need to look at. Very carefully at your um, when you're comparing your options, okay, and choose the best option that is going to work for you. These come right out of your paycheck. Know that, okay, because these are employer sponsored programs. So they will come directly out of your paycheck. So this is, like I said, when you're working and you have bills to pay, kids and things like that, make sure that you really look at everything when you're making your decision about which plan to choose. We also have to explain this to our patients sometimes or our clients as well, um, because some of them may not understand, some of these terms either. And then we have our public health insurance. We have Medicare, Medicaid, and Veterans Administration. So the Veterans Administration provides comprehensive care to all veterans. Okay, so they need to be a veteran. And there's hospitals, there's clinics, there's nursing homes, there's domiciliaries, there's all sorts of resources there. But we will start with Medicare. So again, in 1965, Medicare was added to the Social Security Act. It is a federally sponsored entitlement program that helps finance healthcare for persons older than 65 and their spouse. They have had a 10-year record in Medicare covered employment, and they have to be a citizen or a permanent resident of the United States. So anybody that's ever looked at a pay stub, okay, you will see that there is a Medicare deduction in your pay stub. And so you have to have paid into it for at least 10 years in order to be eligible for Medicare. You also must be a citizen, or I said that coverage is also given to certain younger people with disabilities and those with end-stage renal disease. Okay, so your end-stage renal disease, especially if they're end-stage, are usually going to be on dialysis, right? Coverage cannot be denied based on past medical history. Okay, so again, they have to pay into it for 10 years. They have to be a resident or a permanent citizen, and they have to be over the age of 65, or they have a disability, or they have end-stage renal disease. There are different parts to Medicare. Okay. So Medicare Part A is the hospital insurance for inpatient hospital care. So inpatient hospitals, care in a skilled nursing facility, hospice care, some home health care will be covered by Part A. Part B is the medical insurance. So that is the physician services, outpatient care, DME, preventive services would be covered, as well as diagnostic tests will be covered under Part B. Part C is what we call a Medicare Advantage plan, and these are offered at private companies that contract with Medicare. So usually you'll start seeing these commercials somewhere around October because Medicare open enrollment is in December. And so you'll start seeing these commercials for Medicare Advantage programs on the TV. Um, they Part C also may offer some prescription drug coverage because Part A and Part B for Medicare does not offer prescription drug coverage. Okay, go figure. Um, so this can be like HMOs and PPOs, special needs plans, Medicare savings account plans. There's a variety of your Part C. And then we have Part D, which is the prescription drug coverage. This is offered by insurance companies and other private Medicare approved companies as well. And so we had that Medicare drug legislation that was passed in 2003, I think it was, that provided prescription drug coverage, especially to, pay for brand name medications at certain pharmacies. So again, Part A did not pay for prescription drug coverage at all. It was crazy. Oops. We also have what's called Medigap insurance. This is private insurance that people can buy to cover Medicare or items that Medicare does not cover. So like the med deductibles, the co-payments and co-insurance, things like that. This is another out-of-pocket cost for most people as well. You can enroll in Part C and Part D at the same time. Even though we think, well, we're getting the additional right prescription coverage. Nope. So you can't have Part C and Part D. If you have a Plan C that includes prescription drug plan and you try to join a Medicare prescription plan, you're going to be unenrolled from your Part C. So they're strict when it comes to these things. Medicaid, on the other hand, also was added to the Social Security Act in 1965. Um, and sorry, and Medicare, or I'm sorry, Medicare, Medicaid provides medical assistance for eligible families and individuals with low income and resources. And so it is a cooperative venture jointly funded by federal and state governments. Okay. But the federal government just provides broad guidelines for Medicaid. Each state establishes its own program services and eligibility requirements. So let's say if I'm eligible for Medicaid here in Texas and I decide to move to, let me pick a state, Arkansas. Okay. Um, if I'm just because I'm eligible for Medicaid here in Texas does not mean if I move to Arkansas that I'm going to be eligible for Medicaid. Each state makes its own eligibility requirements. So that is something if we have a Medicaid eligible family, if they are planning on moving out of state, they need to look into the requirements because it is not like you can't transfer it from one state to the next. Undocumented immigrants and legal immigrants who have not resided in the US for 5 years are not eligible. We also have CHIP. I love CHIP. CHIP is a great program. So CHIP is the Children's Health Insurance Program. It is based off of it's based off of income. So it provides medical assistance for eligible kids. It covers uninsured children up to their income guidelines. And it's free or low cost health insurance for kids up to age 19. When I worked in peds, I had a lot of kids that were on SHIP. And the benefits were really good for them. So health insurance, unfortunately, the premiums do continue to increase. So annual increases are something when you look at and you have to do your open enrollment every year, annual increases are something that you will see. The Affordable Care Act does require that the insurers have to justify if the increase in the premiums is completely unreasonable. Like if it's crazy, crazy high, they have to be able to justify why they're making such a huge increase in their premiums. The uninsured, um, so uninsured, um, these are usually include our low wage employees. Then usually they're, in low wage jobs, they're less likely to have insurance benefits. It's also our middle class. Some of our middle class are unemployed, and those employed may be priced out of healthcare insurance because of the high insurance premiums. So again, still a huge issue, even though the Affordable Care Act has done a lot of things to try to increase, right, the number of people who have health insurance. We still have a large number of people in the United States that don't have it. The other alternatives to paying for healthcare, of course, if they qualify for Medicaid, we want them to get Medicaid. They may have to pay out of pocket. There's charity care that may be able to help, or they could face medical bankruptcy. And so it used to be back in the day that your medical bills did not affect your credit score. But now, if you have unpaid credit or unpaid medical bills, it can affect your credit. All right, before we get to prospective payment system, let's take a break. Be back at 7:35. All right. So let's go back to that prospective payment system. So I talked about the DRGs a little bit earlier. Um, So, prospective payment system is a system of reimbursement that pays a predetermined fixed amount for per patient admission, regardless of the actual cost to provide the care. Okay, so that's based off of that DRG, the diagnostic related groups for inpatient hospital services. So the government is going to tell the hospital, hey, this is how much you're going to get. They're going to know in advance what they're going to get reimbursed. So again, you have that heart attack patient that comes in, they're going to have this fixed amount of money that they are going to get to care for that payment for that patient. And so it's a really big, strong financial incentive for hospitals to control their input costs and to reduce and resource use. So cost containment. And so it has been criticized, again, like I said earlier, as promoting abbreviated hospital stays and services leading to a reduced quality of care, right? So they're trying to stay within that allotted amount of money to provide that care, and that's why this has been become an issue. So that DRG, or that diagnosis related group, it's an attempt to stop the skyrocketing costs of healthcare. So they use a math formula to arrive at the fee that the government's going to pay for hospitalizations. Again, they are told in advance how much they are going to get reimbursed. So they've received a flat fee for each DRG category, regardless of how long they stay in the hospital. So it's an incentive to treat clients, discharge them as quickly as possible, right? Because before, come in, oh, we'll keep you for a few extra days. And, that's just going to be, right, more money in our pocket. So that leads us to quality and safety. All right. So, nursing actions to improve quality in healthcare. So, there's a couple of different things that you will see as you get into your first positions. So one is called CQI. The CQI is continuous quality improvement. All right. So what happens if there's any patient harm or a mistake? So maybe there's a med error, or something else that occurs. This is a review of what happened after the fact. Okay. So we're going to look at it. We're going to sit down as a committee and we are going to review the facts, right? What happened? What could have been done better to prevent it so that we can prevent it from happening again in the future. All right. We also have the aims of the Institute of Medicine for improving quality in healthcare. And so there are 6 aims of the IOM to increase quality in healthcare, and they are referred to as STEEP. S is for safe. So S is avoiding injuries to clients from the care that is intended to help them. T is for timely, reduce waste and sometimes harmful delays for both those who receive and those who give care. The first E is for effective. So provide services based on scientific knowledge to all those who could benefit. And then, of course, avoiding services in those who would not benefit. This second E is for efficient, avoid waste of equipment, supplies, ideas, and energy. The third E is equitable. So it's providing care that does not vary in quality because of personal characteristics like gender, ethnicity, geographic location, socioeconomic status. And P is client-centered care. So care that is respectful and responsive to individual client preferences, needs, and values, and ensure that client values guide all clinical decisions. We also have continued competency in continuing education and certification. So as a future LPN, there are some certifications that you are eligible to attain. So IV certification, long-term care certification, Then if you choose to go back to get your RN, there are additional certifications that you are eligible to sit and test for.
Lo compré en bulk.
But this is an important part of it. So of course, maintaining your license does require that you continue or do some continuing education, and that is state-based. So always make sure that you look at your board of nursing requirements to make sure that you are um, meeting your continuing education credits. And each state is different. And it's different for LPNs, it's different for RNs, it's different for nurse practitioners. So you have to know what your individual state requirements are. Look at improving safety in healthcare. We have the Joint Commission on National Patient Safety Goals. And so, safety first, that is one of those ethical concepts or ethical principles from the American Nurses Association. So the National Patient Safety Goals are going to vary depending on what area of healthcare that you live in. So if you go to jointcommission.org and you look at the National Patient Safety Goals, you'll see that there's goals for inpatient hospital or acute care hospitals, long-term care, ambulatory care. So some of them are very similar, some are the same, and then others, they may differ. This one is really cool. I think it's really cool. It is the transition to practice. So the transition to practice was an initiative by the National Council of the State Boards of Nursing, or NCSBN. Those are ones that write the NCLEX. And it's aimed at improving the quality and safety of healthcare by improving the new graduates' transition to work. And so it's an evidence-based transition to practice model. And so for acute care settings, it recommends a 9 to 12 month program to aid for new nurses to transition into practice. I don't know, and not every hospital has implemented a transition to practice program, but these are some really awesome programs. And then other things would be like, oops, sorry, I hit the wrong button. Cost containment and knowing your role in containing costs. And we'll go into that a little bit more. The pay for performance, or the P4P. So P4P is more of an incentive program. And so it rewards hospitals for meeting and exceeding standards of care for a variety of diseases like your diabetes, your heart attacks, your pneumonia, your heart failure. Um, and then we have what are called never events. And these are the things that we try to avoid as much as possible. So never events are serious and highly preventable events. So things like your hospital acquired infections, could be injuries from a fall. Hospitals don't get reimbursed for never events. Okay. So let's just say, all right, you have a patient who is a fall risk, and we haven't put all of the implementations in place to prevent that patient from falling. That patient falls and breaks the hip. Okay. And now we have to do surgery. Um, and so, they have to have a hip replacement, or they have to have rods and things placed in their hip. The hospital isn't going to get reimbursed for that. Okay. That is care that is going to have to be, the hospital is going to have to absorb. So again, there's a big push for quality care versus quantity care. This could also be if a patient develops a pressure area because the proper, protocols have not been put in place, or sometimes even if the proper protocols are put in place, we know that things can happen. But again, if a never event occurs, that hospital is not going to get reimbursed. So this is why we put a big emphasis on quality of care, not quantity. So we want to make sure that we're avoiding those catheter associated UTIs, the ventilator assisted pneumonias, the pressure areas, the falls with injuries, and other things that could potentially put our patients at risk. Another big push is readmission reduction. So we talked about how with some of the changes with PPS and the DRGs, right? Um, so let's say we discharge that patient that had a heart attack and, 2 weeks later they come back to the emergency room and they get readmitted. Then that hospital is going to get a reduced payment if they are readmitted to that hospital within 30 days. Could be day 29. Okay. If they are readmitted within 30 days, that hospital is going to get a reduced reimbursement. So heart attacks, heart failure, pneumonia, COPD, total hips, or total knees, hips, coronary artery bypass graft. Those are some of those diagnoses. Again, they are readmitted within 30 days. That hospital is going to get a reduced payment. This was steep. We talked about this. So these are some of the national patient safety goals. Okay, so the goal here is it reviews adverse incident studies on causes of serious harm and death to clients. So way back in 1999, all right, the Institute of Medicine, they did a study, and they published a paper. It was called, what was it called? It was called Air is Human. There's more to the title, and I can't remember the whole title, but they wrote this paper, or they published this paper. And so it estimated that 44,000 to 98,000 Americans die each year as a result of medical errors. Okay. And we think, oh, well, 1999 was a really long time ago, right? How pertinent is that information today? So in 20, I think it was 2009, or is it 2019? It was one of those. They did a follow-up to the initial study. And even after reviewing the initial study and putting some safety guidelines into place, we did not see a significant reduction in these numbers. Okay. We still have people dying every year as a result of medical errors. And it's high on the list is medication errors, but that's not the only cause. Um, Improper client identification is often a problem in giving medication and also in doing wrong site surgery. So I don't know if anybody heard about this, and I think it was a provider in Florida. Patient died because he was supposed to take out his spleen and he took out his liver instead. Did anybody hear about that? Nobody heard about that.
We
Um, so go ahead, I'll use, I'm sorry.
we hear about it.
Yeah. So, I mean, it's horrible that, you hear about this, right? People going in, they're supposed to have like, their left foot amputated for some reason, and they come out and the wrong foot was amputated. Or, like I said, I was another one where patients, the wrong kidney was removed, or it's just some of the stuff that you hear is just insane. So, nurses are often involved in client prep for surgery and marking the site so no confusion exists during the surgical process. There's a variety of different safety steps that we use, right? Think about your 9 rights of medication administration, right? Your 3 checks. Um, when we look at surgeries, marking the site is super important. They'll do what's called, they'll do a timeout in surgery. Okay. So before the patient is put to sleep, okay, they'll do a timeout. They'll identify the patient. They'll identify any allergies. They'll, ask what the procedure is. Um, so they have these safety timeouts to try to prevent these situations from occurring. Unfortunately, like I said, they are still occurring. So when we look at the one, like I said, with the national patient safety goals, they're going to be different depending on what area of nursing or what area of healthcare you're looking at. So the national patient safety goals for long-term care. Improve the accuracy of resident identification, improve the safety of using medications, reducing the risk of healthcare associated infections, reduce the risk of harm resulting from falls, and then preventing healthcare associated pressure ulcers. Does anybody work in long-term care? Nobody works in long-term care. Have you guys done um, clinicals in long-term care? Yes. So anybody seen an armband on their residents in long-term care? Anybody look?
And arm with that?
An armband, like their name
Never
band?
seen one on any patients in long term.
Nope. So again, 100 years ago, when I was in long-term care, we did used to use armbands. Okay. They would have armbands and it would have their name, they have their date of birth. Forget what else was on there. And of course, our allergies, they would have an allergy band. And with some of our residents, we put them on one day and we go back the next day and they'd be gone. Okay. And I don't even know where they would go. Like some of them were never ever found again. Um, So now with the EMR, okay, we put pictures in the EMR so that when you're pulling up your MAR, you're pulling up that residence record, there's a picture of that patient, right? So when you're passing medications, you can associate the patient's face to the picture that you see on the screen. Pressure areas and harm from falls will always be a concern in long-term care for a variety of reasons. For one, we don't have the safety. I don't want to say safety because I don't think they're even any safer, but we don't have some of the same options in long-term care that we do in hospitals, right? Can't use bed alarms, can't use side rails, right? And so it is a little bit trickier, right? Because long-term care is their home, right? It's considered their home. So they don't have the same options. And pressure areas. Some facilities are really good at preventing pressure areas. Other facilities are not so much. With the hospitals, when we look at the national patient safety goals in the hospital, again, it's improving the accuracy of client identification. We always use two patient identifiers, okay? Name and date of birth, usually the most common ones that we use, right? It's also improving the effectiveness of communication. So SBAR is an effective way to improve communication. Medication usage, reducing harm with clinical alarm systems. So, working in a hospital, I mean, even working in long-term care, um, call bells are going off, bed alarms, IV alarms. If you're on the ICU, you may have ventilator alarms, right? Got all these alarms going off. And there's truly it is called alarm fatigue. Okay. Sometimes you get to the point where you just don't even hear the alarms anymore. Um, and so, of course, we teach you when you hear an alarm, you go and respond. Reducing the risk of healthcare associated infections. And then the hospital identifies safety risk inherent in its client's population. And then, of course, like I was saying, the timeout, so that universal protocol for preventing wrong site, wrong procedure, and wrong person surgery. So I think this is, the last couple slides. So we look at improving the cost of healthcare and cost containment. So, a variety of things that you can do here. For one, follow your policy for charging clients for supplies used in their care. Some hospitals have, like, you have your your Pyxis machine for medications. You may also have a Pyxis for supplies. So if you need to start an IV, you have to go into the Pyxis. You have to pull the IV start kit and the supplies for that client. Others just have an open stock room. So it depends on what your hospital system is. Same thing as far as documenting client care for reimbursement. Be mindful of this is something that, I think it's forever been a problem. When you are going in to provide patient care, so let's say you need to do a dressing change, okay? And this is an exaggeration, okay? But if all you need is a Band-Aid, don't walk in with, you know, a whole pack of, 50 4x4s if all you need is a Band-Aid, right? Um, go in with just the equipment that you need. Anything that you bring into a client's room that is now that client's. So it doesn't matter if it's opened or unopened. Once you pass that threshold into that patient's room, it is that patient's. So if you're doing a dressing change, you don't need to bring, 3 rolls of tape and a whole bunch of extra dressings. Just bring what you need. If you're doing a linen change, it's the same thing. Once you walk past over that threshold into that client's room with that linen, it doesn't sound like anything, right? Because it's just linen. It's not like it's getting thrown away, but you can't use it for anybody else. It is now dirty. So now, really just wasting services to rewash clean linen, right? Because we brought it into a client's room and we didn't need it.
So that was because they were being nice.
I'm sorry.
I saw that they they leave the extra stuff because they were being nice.
Now, yeah, in long-term care, that is actually a very common practice. I remember this is kind of it's a ridiculous story actually, but we I don't remember what happened. It was one of the when I was a corporate nurse and I was traveling, one of our facilities, we had no washcloths. Couldn't find washcloths. So we literally did a building sweep. So we went into every residence room and we looked in every drawer and every closet. We found all the washcloths because the CNAs, and you're right, a lot of times linen is scarce, especially in long-term care. But yeah, so now in addition to, we have residents that would have washcloths and towels as well. But yes, I'm going to put this in here for later and then you forget, right? And so then it gets to the point where it's all missing. So just be mindful of that. And then, yeah, so I think I probably said something similar to this, probably in one of the beginning classes. You guys, as new grads, are going in with fresh eyes. Okay. So you're going into healthcare with fresh eyes. And so you are in a unique position to recognize practices and procedures and even sometimes policies that may be outdated or they're not efficient. And so be a problem solver. Look for ways to make those practices better and more efficient and present those to leadership. Um, because, that is how we make changes, right? That is how we improve. And like I said, by coming in with fresh eyes, you're in that unique position. So you can look at tasks or protocols that could be done more efficiently, and be a role model. And that's always a big thing. I forget, I was talking with another class and we were talking about incivility in nursing. And I will tell you, you get to go out and be the nurse that you want to be. 100%, right? You get to choose the type of nurse that you want to be. Um, do you want to be an innovator or do you just want to fly under the radar or do the things that you want to do? But you get to be the nurse that you want to be. And we, of course, need nurses in all aspects of healthcare. But just think of, I think of you guys, you're, like I said, you're going in with fresh eyes, and you get to see some of the things that could potentially be changed and fixed. And you guys are really the future of nursing. And so I don't know, how soon I know some of you want to go on and get your RN or even move on to get your nurse practitioner and other things. But go in with an open mind and really look to see what things that you can find that you can improve upon. That will help you to network, that will help you to gain experience. It'll also help you move up, if that's what you choose to do. Um, there's so many opportunities for you in nursing now. So, again, you guys get to go out and choose the nurse that you want to be, and, make it a great experience. And you can make it a positive experience for yourself as well as people that you work with. And, even future nurses, because as new grads going into the workforce, you're going to be exposed to students, right? You're going to be exposed to more senior nurses, and there's always going to be another new nurse coming around. So always be that positive role model, be positive, be enthusiastic, and go out there and just make changes because that is exactly what we need to do. All right, so we did cover a lot of information in chapter 16 as well. So any questions on chapter 16? All the insurance stuff. No questions? All right, I'll ask questions then. What is Medicare Part A? What does Medicare Part A cover?
Covers hospital visits. Hospital insurance, inpatient hospital care.
Very good. Yep. So it covers your inpatient hospital care. What does Part B cover?
Physician services.
Basic service.
Okay. Um, let's see. How are you eligible for Medicare?
If you work 10 years and
Below
65
65.
si-
or have a condition, a chronic condition or a medical condition.
Kidney disease in the state, something like that.
Okay, so yes, so you have to have paid at least 10 years into it. You have to be over the age of 65, or you have a disability or end-stage renal disease. You have to be a citizen or a permanent resident. All right. How are people eligible for Medicaid?
um,
They have to be a U.S. citizen
Okay.
and live in what is it?
Mm,
If they're not, they have to.
that based on the income and also
Their
any
income, yeah.
Yeah.
Yep. So Medicaid is for those with low income. Absolutely. Who runs the Medicaid programs?
the
The
Government?
What type of government?
health and
The state. Remember, the state
state.
establishes its own services and eligibility requirements. Okay. So the federal government just does like broad national guidelines, but the state is the one that just establishes its own services and eligibility, right? So I said, if I have, like, let's say I'm eligible for Medicaid here in Texas, but I moved to Arkansas, I may not be eligible for Medicaid based on what their eligibility requirements in Arkansas is, right? So it's state run. Let's see. Let's see. What is a deductible?
what you
It's the amount you're responsible for paying before insurance kicks in.
Good job. Absolutely. So it's the amount that you are required to pay before your insurance kicks in. Um, let's see. Trying to think. We covered a lot and I'm trying to just like get it all together. Um, what is continuous quality improvement? What is a CQI?
is Mhm. The when you get a patient in the hospital that is the one that you try to have the patient in the less amount of time on the hospital.
Say that one more time.
Is the one that you have that they're asking to have the patient the less amount of time on the hospital.
Oh. No,
Mm,
CQI is quality improvement. So this is if we have a pressure area, a fall, an infection. We're going to look at the events after it happens. We're going to go back and we're going to review the events that led up to that occurring and determine what we could have done differently, better in order to try to prevent that from occurring. Nicole, are you there? I don't see Nicole. Um, and then I see Katrina. Um, so yes, so it's kind of like a review of the past to see how we can move forward and do better.
okay.
Um, we talked about the national patient safety goals. Talked about cost containment. What else can I ask? Um,
Was she talking about the DRGS? That's what she was talking about,
I
like
think,
the
yeah.
set amount of pay for reason of visit.
Yep. So that's the DRG. Yep. Your diagnosis related group. So again, that's the set amount of money. So you have your heart attack patient, like I said, they know the hospital knows like this is what my reimbursement is going to be, right, for this diagnosis. Now, I wanted and probably should have clarified this. Now, a lot of people, when they're admitted to the hospital, they're not just admitted with one diagnosis, right? They usually will have a couple of different diagnoses, okay? So they'll take all of those DRGs. It's not just one DRG. I just use that as an example. So I just wanted to clarify. If they're having a heart attack, okay, that's one DRG, but maybe they've got uncontrolled hypertension, right? So that would be another DRG. And if they have, diabetes, right, that would be another DID, oh my gosh, DRG. So again, it depends. But most of your patients are going to have more than one DRG. Um, and that prospective payment system. And like I said, the hospitals know, and that's why there's such a big push for cost containment. And it's not, and I want to be careful and say that it's not about providing the minimal amount of care either, right? It's about not wasting resources. And that's why I said, if you're going in to do wound care and all you need is a Band-Aid, right? You don't need to bring in, 54 by 4s. There's going to be times where I don't know, how many of you have put in a Foley catheter? Nobody's put a Foley in?
Practice.
Just practice, but not. So I've been a nurse really long time. Okay. And I will tell you that a lot of times with a female patient, not with a male, although I shouldn't say that. One time I actually had to get another one, but I'll always use, I'll bring my kit and I usually will bring an extra Foley just in case because with females, okay, there's lots of different variables that can occur that you may not get it in the urethra the first time. And I actually had a male patient, which was really surprising, um, that had an enlarged prostate, and I could not get the Foley to advance. And put the Foley in, and literally it would just bounce right back out. So I ended up having to waste a catheter, which is surprising because you would think male is a lot easier to catheterize. But we have a huge role in cost containment. And like I said, once you bring something into a client's room, and it doesn't matter what setting it is, if it's in the hospital, even in a long-term care setting, once you bring something into that client's room, it is now that client's. Can't bring it out and use it for somebody else. That includes wipes, like if you're using the personal care wipes, you can't. bring a package in, change one patient, and carry that package out and bring it into another room and use it on another patient. And that's why sometimes if you see there's a shortage of wipes, you'll see CNAs will keep them outside the room and they will just grab some and go into a room, right, with a couple of those wipes to go in and clean their clients. So that's what I mean by cost containment, just being, aware of what's going on and not providing any waste or not promoting waste. But all right, it is just about time. So no other questions. Are you sure? All right. So I hope everybody has a great week, a great weekend, and I will see everybody next Wednesday. Y'all have a good one. Be safe.
Thank you. See you next week.
Yes, ma'am. Bye.